Good morning to you in South Africa. Very good morning to you, and I'm very happy. It's my big pleasure to be with you. I remember my interaction with some of you at the last One Health conference in Cape Town last year, but also at SV in Sydney. That I talked with some of the organizers, and they said I should come to give the talk. And thank you for inviting me. But for sure, I will be there with you from tomorrow morning. As I will travel from tonight from Nairobi. I'm very. Let me tell you that I like very much the opening remark of the president, but also the representative authority of Mpumalanga. It looked like that we are just good place to talk about One Health, and that is also the reason I accepted this talk and share with you some of our experience on One Health from INRI, but also from other organizations we are working with, in the perspective to work together to how to operationalize this interesting approach. And that's why my talk is really about how to operationalize One Health, how to turn this powerful approach into action to improve the health of our people, but also animals and the ecosystems. I would like first to acknowledge the contribution of many colleagues in my group. I was the program leader at INRE, where I led a group working on animal and human health, and this is my team, but also acknowledge the contribution of some of the key people with whom I have been working for decades, in particular Professor Delia Grace from NII in the UK, but also my former boss Jacob Zingstad from Swiss Tropical and Public Health Research Institute in Switzerland, and also our colleague Sham from FAO in Ghana, and also our policy colleagues from Kenya. And my talk in the next 40 minutes or so, I will address a few things. I will talk about, the history and the concept of One Health, and showing some of the experience at global level, how we operationalize One Health from research and capacity building. And also at the end, I talked about the added value, the benefit, and how we can invest to make this approach work on the ground. I already like very much the remarks of the president and also authority from Mpumalanga. We need resources, we need investment to make this approach work on the ground, and coming up with some conclusion. Okay, so I'm from the International Livestock Research Institute, INRI, in Nairobi. So you are very welcome to visit our campus in Nairobi here. So we have lab, we have farm, we work mostly on animal health, but very much connected to human and the environment. We have also a conservancy, the Wildlife Conservancy, not far from Nairobi, about 60 kilometers from Nairobi, where we have livestock, but also wildlife. So offering a very nice ecosystem to do One Health, which is the topic of today. And actually, for those who are not familiar with my institute, we are part of the so-called CGIAR systems, that is the international partnership for agriculture research. We are celebrating 50 years because we have been working on food security for the global south for many years, with 10,000 people working on over 100 countries and partners with many countries and organizations, including some of you in the room, I suppose. And most of the organizations are based in the global south. And here at INRE is a research institute mostly on livestock. So we want to improve the life of people through better livestock, moving also to improve the human health and the ecosystem health. And we have different campuses to achieve this mission of INRE. So now let's come back to One Health approach. I think that the audience, when I look at the actually participants list and composition and of the program, I see that obviously many people working on animal health, but this One Health approach is going beyond the animal health that we are talking. And this actually, we are working really to address the very big challenges linked to our agri-food systems nowadays. Because agriculture is responsible for about 40% of gas emissions, threatening also loss of biodiversity, deforestation, but also account for 70% of global fresh water use. And also, the food waste also is a big issue that we are addressing. We have to address 30% of which we are the food we are actually producing are wasted. But when we talked about One Health recently, One Health become more popular because of these global challenges we are facing linked to the global health. In particular, the first one, zoonotic diseases. Emerging infectious diseases and zoonotic diseases increased for the last decades the frequencies. Just to name a few, COVID-19 caused a lot of health and social impact for our life. Now we are traveling again, but you could remember 4 or 5 years ago how difficult we were with this COVID. And of course, now we talked about avian influenza, rabies, MERS, Ebola, Marburg, and so on. Most of them are zoonotic diseases, and we need to address this. The second areas we are very much concerned is about antimicrobial resistance, AMR, both from people, animal, and the ecosystem, killing about 1.2 million people a year, and we need to address this. And the third one is about food safety. The foodborne diseases, causing a comparable global health of, the burden of health equivalent to HIV/AIDS, tuberculosis, and malaria, but the investment for this area is very minimum, not proportionally to the burdens that they are causing. So to address this complex issue of zoonotic diseases, food safety, AMR, and others, we need a more comprehensive and integrated approach. And that is the reason that One Health is coming up, because that is integrated approach to address the complex health issue. And recently, the quadripartite organization developed the One Health high-level expert panel, or we call OLEP. Some of colleagues from South Africa are part of this group, in particular Professor Wanda from Cape Town and Pretoria, to redefine the approach. And I believe that many of you have been or are familiar with that. This is really an approach defined as an integrated, unifying approach to really aim to sustainably balance and optimize the health of people, animals, and the ecosystem. So what is the difference from this revised One Health definition compared to the past definition put together by different organizations? I think that this revised definition of One Health become more, comprehensive and open more perspective for different stakeholders to use this and operationalize this to protect the health of the people, animal, and the environment. Because it recognizes actually the interconnection between the health of people, animal, and the ecosystem. It's very important to recognize this, but also it needs to mobilize the intersectoral collaboration. Different discipline, different people have to work together, in particular people from public health, people from veterinary medicine or agriculture, but also people from the environment need to work together. And beyond that, you have also as a discipline need to be involved. And finally, the One Health approach was initially championed by vet people, that many of you are. And more, we need more people in other sectors. And it's mobilized really the society at large. And it did not only for zoonotic diseases, food safety, AMR, but we can talk about broader issues like communicable diseases, air pollution, nutrition, also be part of the discussion of One Health. And obviously, you see also the ecosystem, including One Health, here mentioning the wildlife and plant health, where we are sitting over there. There's a large ecosystem with a lot of wildlife is also very important. So that is kind of the new revision of the concept of One Health. But One Health became only very popular for the last, I would say, 20 years because of zoonotic disease. When even influenza and SARS outbreak happening in China 20 years ago, almost 20 years ago, you see this One Health become popular, and now everyone and everywhere talked about One Health. But when you look back in the history to link a little bit on the concept of health that people talked about, here you can see one paper from China showing that in the Chinese traditional medicine they talked about the connection between people, animal, and the environment, something like 2,700 years ago. You see, so that is not something new. People always perceive the importance of the interconnection between people health, animal health, and the ecosystem. In 19th century, come back a little bit to the history, we can say also that you see, actually there's also a strong interest in the comparative medicine, and here the German Rudolf Virchow, emphasized that between animal and human medicine there's no dividing line, and it nor should there be. The object is different, but the experience to obtain the constitute of basis of own medicine. And really in 60s, the concept of one medicine coined by Calvin Schwaber for different research in Sudan, actually showing that there's no difference in paradigm between human and veterinary medicine, and that's why the science shares a common body of knowledge in, for example, anatomy, physiology, and so on. And this is actually leading from one medicine to the One Health. But when you look at the One Health from understanding from different perspectives, I don't know, you have medical people in the room, the medical vision on One Health sometimes is very different because they focus more on specific diseases. That's why they talked about bacterial infection, viral infection, and so on. But when you move to the development vision of One Health, here I'm citing the example of IDRC in Canada. They look very much at different principles on transdisciplinarity, the participation, the social agenda equity, the knowledge to action. That means the eco-health approach, ecosystem approach to health is another approach. It's very close to One Health we are looking at. But when you look at the global vision, so now people talked about planetary health, you can go see a gradient of interest in health of people, in public health, in global health, in One Health we are talking about. And now we take care of the health of our planet, moving to planetary health. So you see, depending on the interest, on the angle of the views that stakeholders having, we have different definition of One Health. And finally, here, if you talk about ecosystems vision, people talk more about climate change, the land system change, the fresh water, very much environmental health going in. So the One Health is interesting, but depending on the perspective, we look at it from different angles. And here's the last vision I would like to mention here is about agro food systems. Of course, we produce a lot of crop, we produce a lot of livestock. And for that, from the food production perspective, we are interested not only on human and animal health, but also the soil health, the plant health, the agro ecosystem, and so on. And finally, this food system, when we produce food, now the UN just had the UN food system in Addis Ababa a few weeks ago, the second time. The food system concept is become popular, but when you produce food, it is part of the ecosystem. It links really from the food supply, food environment, the consumption of the food, going to the diet, nutrition, but you also have the social, political drivers of food production, and this link to the foodborne diseases, the disease emergence, the antimicrobial resistance, even the occupational health, and overnutrition and hunger, and so on. So you see, it's a very much systematic view of things that we are talking here. And I come back to this approach, and to make this approach work, you have mobilized the collaboration and the motivation and engagement from different levels, really going from local level. Here we talked about the place we are sitting there at district level in South Africa, I would say, going up to the national level, but also global level. And at global level, we have the quadripartite organization working on One Health that include, WHO, FAO, VOA, former OIE, that's why you see the former DG here, and UNEP is also part of this quadripartite to take care of the environmental aspect of One Health, and they develop the framework, the so-called One Health Joint Plan of Action, and coming up with guidelines for different implementation level in the country and in the province. And here I just want to bring the attention to the 6 One Health Joint Plan of Action Track, they call Action Track or AT, that includes the enhancing the One Health capacity to strengthen the health system. You have also AMR, food safety, zoonotic diseases, but also integrating environmental health into One Health. That is also one of the key recommendations of that document. So I have the pleasure to be part of this One Health high-level expert panel. I mentioned that in South Africa, we have Vanda and some other people globally to help this quadripartite organization with some recommendation and providing more evidence how One Health work, so that it can accompany country and different levels to work on this approach. Okay, so from regional level, here we are in Africa, it's relevant to see how the structure of One Health works. So of course, obviously, you can see here different technical working group addressing different action tracks, like I mentioned before. But you have also the regional coordination group of these 4 organizations at regional level, working with the global quadripartite secretariat, and they rotate between these 4 organizations. This year is actually in the hand of FAO at the moment. Last year was UNEP and the OLAPs I just mentioned, who support all these people. We have also different frameworks here. For example, the African CDC developed different strategy on zoonosis. Next week, in September, they would launch another strategy on food safety and so on, and working with different economics community to really bring the resource and also the policy into One Health. And I'm sure that in our South African countries are also champion, in particular South Africa, have a lot of knowledge and technical expertise to implement that approach. And, very often, every country, most of the country in Africa now, they have the so-called the national One Health platform established among, in the continent. You have already 34 countries in sub-Saharan Africa have this coordination, and they have different names. They can call, from ZDU, Zoonotic Disease Unit in Kenya, to Cote d'Ivoire. They have also, One Health platform and so on. So many people have this governance structure, and also they have actually do the national bridging workshop, bringing actually the IHR, the International Health Regulation, to PVS, Performance of Veterinary Services, together, so that the public health and animal health people work too closely together. And noting that the environment people are not there yet. And you also at the regional level, you have major One Health networks in Africa. This list is not comprehensive. Just to name a few, for example, the Africa one is really a 12 or 15 years project funded by Wellcome Trust and as a donor, developing the capacity of One Health research, focusing really on the postdoc level, led by my colleague Basiru Bonfo, based in Cote d'Ivoire. And you have Afrohun, obviously focusing on capacity building in university, but you have also capacity One Health in Eastern and Southern Africa, One Health Center in Africa. These 2 projects led by INRE, also HEAL, in working on pastoralist area, Prisot initiative initiated by French and now become global, and Africa One Health Network and so on. So you see, you have a lot of network and project around. And the question both, in fact, how we really optimize this approach in terms of research and capacity building in Africa to really help people to prevent the next pandemic and also improve the key issue of zoonotic diseases, food safety, AMR, and so on that I mentioned from the beginning. So here, I just want to share a few experiences from my own research institute, how from an international research institution can address the One Health agenda. I would like to talk about that because that is actually our actual work together with partners. And I think that, hopefully that some of this experience can be learned, can be shared for other country, and it can go down to different level, in particular national and local level. Okay, so during COVID time, of course, INRI have worked on animal health and human health for the last 3 or 4 decades, but at that time we didn't go on One Health. And during COVID time, we developed the research strategy for One Health, focusing on a few areas, here in particular epidemics and pandemics, foodborne diseases or food safety and antimicrobial resistance. You can see here the areas we focus is really the technical areas, because we are from research institution. We need to generate evidence, we need to publish, we need to come up with innovations to control diseases and so on. So that is our key work. But also more and more we work with policies really to move policy forward and also develop institutional capacity building. And this is three interlinked pillars of our One Health. Is really technical, policy, and institution development. We have a portfolio of research projects in One Health. Some of them I cited already, like Oreca and Cohesa. We are both active in some of Southern Africa. But we have also the CGIAR One Health initiative. So I had the pleasure to lead it for the last 3 years, and many bilateral projects funded by DITRA, by Wellcome Trust, by Gates Foundation, by Asia Australia, by World Bank, by FCDO, and so on, working on different areas. So the approach is very much aligned, because if you want to do One Health from a research perspective, for example, here the CGIAR One Health initiative, here actually we always have the key pillars of One Health about zoonosis, food safety, AMR. But you need also to include the environment. Here's a project looking at the role of water on disease transmission, but also looking at the bottlenecks of how One Health can be operationalized better in the ground from the economics, governance, and behavior. You see, so the approach is really to generating evidence, developing innovation, engaging with donor and policymakers to scale up this innovation to prevent diseases from zoonotic diseases, food safety, and AMR. So this is really from research translated into action and policy in every project. The same we have done for One Health Center in Africa. This is an initiative led by our colleague Bernard Beth from Kenya, funded by BMZ Germany. And the approach is very similar. We focus on the evidence generation. We develop intervention. It can be rabies vaccination. It can be, Rift Valley fever vaccination. It can be education on One Health, and also develop network and partnerships. Address at the end the different impact areas here from SDG. But in this particular project, we train about 20 PhD students in different countries, and many of them are from the government system. And we see the pathway of training and working with national people. That is actually a sustainable way to achieve the outcome and impact in the country. For Cohesa project, capacitating One Health in Eastern and Southern Africa is not a research project. It's a capacity building project. We work a lot with the governance and the government people. In South Africa, we work with Pretoria University, because they have skills and capacity to help other countries listed here in 12 countries. In many countries, we actually review the governance structure of One Health in different countries, and we actually publish a special issue on KB health case for 12 countries, how One Health work, and coming up with the recommendation to address the gaps in terms of how country can move forward with One Health implementation in Rwanda, in Tanzania, and in many other countries. So, I can share the link, and you can have more materials from this talk, learning more about the One Health in different countries that we are supporting. But at the end of the day, we need to do real action in the field. And here, for example, an example from Oreca project, One Health Center in Africa, we have the local county. The county is actually the provincial unit, I suppose, equivalent to some of the country here, to actually address the rabies issues for example, this case in Machakos County. So we work with NGO, in particular the VSF Germany, to vaccinate the dog population. And the interesting example to see here is, in fact, now when people bring dogs to be vaccinated, they bring also the donkeys, because the donkeys also get rabies problem, and donkeys is actually a very good resource for them. And in this way, we work more closely with the local authority to mobilize resources to vaccinate both donkey and dog population. And actually, we calculate also the cost-benefit analysis, how much the county government have to invest and how much we can prevent and have the benefit from this vaccination, and with the evidence we can put on the table for the local government, they will see and make a decision how to invest on mass vaccination of dog to prevent the death on human, but also on livestock side. So that is actually the way to mobilize the local authority, working with NGO, working with research organization, with the seed money from project, but from long term, the local authority have to put money on the table to address the rabies issue in the county. So that is an example on rabies. Another example on Rift Valley fever is emerging here in East Africa. So our colleagues from Research Institute here and working with national partners to develop different studies on epidemiology to understand the transmission from animal to people, but also how climate change and climate factor can influence the immersion and transmission, and coming up with a strategy to advise the local authority again how and when to vaccinate timely, dryly the livestock population to prevent disease to jump from animal to people, but also to prevent loss of livestock in the community. So now we have kind of the online platform, we have simulation, we have the contingency plan for Rift Valley fever for Kenya also, and some other Eastern African countries. We develop also with our PhD student here in Kenya how to develop the One Health surveillance, meaning that how to develop integrated surveillance of diseases between animal and people in rabies, in Rift Valley fever, to really target on the emergence and transmission models to come up with the right recommendation for the government to control this type of diseases in different settings. So this is actually capacity building through research, working closely with the government to address a specific problem of One Health we are having here. Probably the last example I want to share here from research and capacity building is about food safety before I move to the cost-benefit analysis and how to mobilize resources for One Health is about foodborne diseases. Quickly, the background is, in fact, I mentioned that the foodborne diseases causing a lot of health equivalent to HIV/AIDS, malaria, and tuberculosis, but the investment is not very appropriate. And when you look at the cause of foodborne diseases, most of them are from microbiology. It's a viral virus, bacteria, parasite. The chemicals is still causing less burden in terms of health burden. So, but the public always are much more concerned about chemicals than microbiome. So that's why, from a scientific point of view, we need to educate the population to understand the right cause of foodborne diseases. In terms of economic loss, foodborne diseases also cause about $115 billion in terms of loss of productivity, but also the healthcare and so on. And most of them are from developing countries. So it's big money, but we are not investing enough to address this problem. And to address this problem is very challenging in developing countries. Here's the case of traditional market, an open market in Vietnam, for example. You see that now most of the pigs are raised from the smallholder, slaughtering on the ground, causing a lot of infections, transporting by motorbike, going to the open market, going to the table. Here we get a lot of chopsticks. We go from farm to chopsticks in that area. A lot of challenge of food safety because of poor hygiene practices, poor infrastructure in the market, and so on. In Africa, in some of the countries we are working here in Kenya and Cote d'Ivoire, for example, the situation is not very good either. You can see here, so addressing the foodborne diseases in this context is challenging, and we come up with different models, doing risk assessment, intervention to improve food safety in traditional market, but also slaughterhouse. And you can see here our conclusions that, when you want to improve food safety in a low and middle income country, you need three things. You need to train people and providing the low cost technology for them. You need water, you need, clean table, etc. for them, and good education, etc. But you have also actually the enabling environment. So our policymaker in the room, please help these people to actually do their job. You need to have an enabling environment good to implement intervention. But on the intervention and policy have to give incentive to people from a social, material, money perspective. And also we need to motivate people to use a new technology. So only and only when you have these three-leg stones to be stable, like this, you can improve food safety from three perspectives from our research. So we run on this randomized control trial of food safety intervention in different countries, Vietnam, Ethiopia, India, Kenya, etc., etc. And we see that, we sometimes when you invest very little, about $30 to $40 per pork shop in Vietnam and Cambodia, you can really reduce the level of contamination of microbiology and also improve the knowledge and practice of people. And actually, if the policymaker supports this kind of innovation, we can actually improve a lot the food safety situation in slaughterhouse and the informal market in some of the country we are working. So the solution is there, but we need investment and motivation and the policy support to make it happen. Here, quickly, how we train people in the market, providing water for them, and also putting the score on door so that the consumer can see how good they are, practicing, how well they comply with the training and materials we provided. And here is shown, so for example, with this intervention in traditional market, you can bring actually the prevalence of Salmonella from 50% to 30% here in Vietnam and Cambodia, which only is investment of $30 to $40 per shop. So you see, it might would, or another solution here, since the slaughterhouse, we provided the metal grid here to separate the carcass from the floor. And actually it reduced contamination to the carcass, and it contribute to improve food safety to the household and the market, because here you can see before intervention everything is happening on the ground, because that is a tradition and people don't want to change. So with simple and low cost technology you can help, and when you have the evidence you can do communication, you can influence policy, you can help the region. And that's why we developed the key report here on food safety for different government. We have the Inter-University Council for East Africa to develop food safety curriculum. We support the African Union to develop food safety strategy, and so on and so forth. So research into policy is very important. Last year, when we was in South Africa, we launched another report on food safety linked to eating wild meat. And the wildlife is very important for One Health approach. And actually, you can have a look more closely how we work on this comprehensive report on wildlife trade and integrate really the ecological and epidemiological and human well-being approach towards the wildlife recommendation in different areas here. Okay, looking at the future, the INRI and CGI work develop a new program now. We have actually working mostly on transforming the food system transformation, and of course we need to work on breeding, on sustainable farming, etc. But among program we are developing here, we have a program on sustainable animal and aquatic food. And of course, when we talked about animals and fish, the One Health is important, and that's why the One Health component are here to accompany and work with other component. You need to increase the productivity of animals and fish, but you need also to work on climate change, on the market, how to, help farmers to trade their product, taking care of gender and social equity. And actually, One Health is part of this discussion among these things. I'm not going to the detail, but antimicrobial resistance is also very important areas. And for that, of course, we should not work only on research, but we have a very comprehensive partnership approach to work also on understanding the use, the driver of use of antibiotics in people and also livestock and aquatic food system, but also come up with the intervention policy and capacity building in different countries that we are working. Okay, so last session, I think that now 10 minutes left for me. I would like to share some experience on actually linking to operationalization or One Health operationalization and investment. Actually, we reviewed recently and we published the paper how to operationalize the One Health at regional level. And this is the case of Southeast Asia, where I come from. We work with national and regional partners here to address, to come up with some recommendation how we operationalize this One Health at regional level. And one as the conclusion we came up with this review and workshop is really engaging with the government and the regional organization. Over there they have ASEAN, it equivalent to EAC or whatever, the economics community here in Southern Africa. This organization need to support and invest, and also actually creating the good enabling environment, like I mentioned, in food safety intervention, so that the One Health can work in this particular region. And also we can canalize and cascade it effort to the country and the county or provincial level, so that One Health can be done and operationalized at different levels to address the One Health challenges. But when it goes to the ground, you need also a very adapted approach and to specifically to address the issue on the ground. And here, the example of our One Health project, HEAL, is a healthy human, animals, and livelihood funded by SDC, and INRI is working with AMREF Health Africa together with VSF Swiss to address this One Health issue in pastoralist area. Pastoralism is very important in Africa for some of the place. So the health services is poor, the environmental services is poor, and the animal health service is poor because it's so remote area. And for that, actually, we developed the so-called One Health unit together with our colleague here, Siobhan Moore. She's a professor from Liverpool, but posted at INRI. So this One Health unit is really a platform to bring professional people from the county or district level. They work on human health, animal health, and environment. And they can be health officers, they can be nurse from human health. In animal health, we have animal health technician people, and the environment people, you have nature resource management officer working on rangeland management. So we form a team, we train them, and here once a month or once a week they go to different places in these pastoral systems to really consult and help people to treat the disease from people, to treat also animal diseases, and also to work with the community how to protect the environment, building toilet, having more water, and so on. So we see One Health is really integrated. It's bring human health, animal health, and environmental health together with your team. And for the last 4 years, this is the number of units that we developed in different countries: Kenya, Somalia, Ethiopia, but also about 50,000 people receive the health services. About 1 million people are livestock vaccinated, and actually also how environmental health was also protected through these activities of this One Health unit in different countries. So you see, it works, and we are evaluating the impact. And last week I was in Marsabit in North Kenya to talk with the local authorities, the county people. They like the model. They see that eventually county can put money to promote more this approach, having not only 18 One Health unit here, but you can have hundreds in different counties in Kenya, Somalia, and Ethiopia, hopefully. Or here, another example how to make One Health on the ground. I show you the photo of Kilimanjaro mountain between Tanzania and southern Kenya, where we have the interaction between livestock and the wildlife. So the zoonotic disease is coming up. So how we address this? So we need to address the One Health on the place on the local level where the One Health issue emerged in terms of zoonotic disease and so on. And for that, we work with the local government to develop the Fin Lab, the One Health Fin site. So here you can see a lab in the Fin in Olotoktok, in the border with Tanzania, where we have vet and public health people in that county working with students coming from universities, with INRI researcher to collect sample on the ground, treat the sample on the ground, and of course doing simple analysis and more advanced analysis can send back to Nairobi or other place to do. So the county of Kajiado also funded position to work in this lab. It shows how PPP, public-private partnership, can work also for the One Health example in this particular ecosystem in Kenya. Or in Vietnam, we travel a bit in far from Southeast Asia. We work with university and community to put together a One Health research site in Thái Nguyên province, northern Vietnam. And we mobilize youth people, young people, the community to address, for example, here when you have a big typhoon killing a lot of livestock, etc. This group organize different activities to clean up the environment, to maintain the healthy environment, people, and the ecosystem. Or from the INRI point of view, we also developed the collaborating center for One Health with VOA. It was approved last May, and hopefully that with this project, we can address the research capacity and policy linked to the disease prevention, biosecurity, but also climate smart strategy with different countries. So brings in the knowledge from research from INRI to help VOA and other countries to address the One Health issue from capacity building, research, and policy perspective. A few last slides to share with you that, when you do One Health, it's not about academic alone. People always refer One Health approach because we talk a lot in the conference. So, researchers are important, but actually to make One Health happen, we need the transdisciplinarity approach. It means that we need to consider the knowledge produced from the academic people, like research institute, like university, but it's very important to include and integrate the non-academic knowledge in the research process. So we need policymakers, we need community, we need knowledge of farmers, and in particular in the area where you have indigenous people. So these indigenous people can have also indigenous knowledge to contribute to how to solve this One Health problem. That's why you have the science here, society. You need also to bring nature and social science and different stakeholders in our society. And when I work on foodborne parasitic disease in Laos, for example, here we bring people around the table. You can see here the decision makers around the table. You can have also public health people, but you have so scientists, animal health, social science. So these people need to talk to come on a same page on the problem that we want to address. So that is part of the Come Across project funded by EU in the past for Laos and Thailand in the past. Final slide. To make One Health work, you need money, you need resource, you need investment. Nothing can be free, even small, you need to put things on the table. So recently I wrote up a cone for investment, coning preventing the next pandemic, One Health researcher cone for urgent action. So the point is very clear. One Health is interesting approach, and it shows that with One Health we can save money, we can save life, we can make money for the country. For example, here the World Bank published a report last year or 2 years ago showing that from cost benefit analysis perspective to preventing a pandemic at global level, we need about $11 billion a year. If you have a pandemic, you need 31 billion annually to address the pandemic preparedness and response. You see, so if you want to invest 11 billion compared to 31 billion to address when the pandemic already happened, the investment return is about 3 to 1. From an economic point of view, it's a big profit, big investment return. That's why we need to invest in One Health approach to prevent the next pandemic. However, when you look at the 11 billion per year for our world to prevent the next pandemic, actually the pandemic fund is very good at the moment, has very little money. It's 800 million for the last 3 years. So pandemic fund is very good idea. So it means that money need to be top up from somewhere, from the government, from local authority. We need to join hands together to prevent disease. And when you prevent disease early enough, here on the left-hand side, it's the cost will reduce to avoid cumulative cost at the end when you have the outbreak here. And for that, you need to invest in the surveillance collaboration. You need to invest in public health, social measure, engagement, resilience, community. We need to do research. We need to also to provide services to scale up different intervention and so on. So all these things showing another time full One Health aspect of how to engage in different partners together. To do that, still the same report from World Bank. We need different people from different states here. you see a lot of UN agency, different international organization, and so on, different key leaders from the rich country, but also the developing country research institute to work together to address this PPR agenda. Or if you go down to the country level, another example here conducted by Jacob Zingstad from Switzerland, Swiss TPH in Mongolia. If you want to prevent brucellosis in Mongolia, you can do mass vaccination, and the benefit is huge for the country. For example, here they put a models when you put vaccinate sheep and goat and so on, what's the benefit you have at the end. And here, without going into the detail, you can see that here's the investment. If you do the mass vaccination for about 30 million sheep in Mongolia, this is the benefit you have from different sectors. You have the benefit from public health benefit, private health benefit, the household income loss prevented from the diseases, the total health benefit, the total coming from animals, from livestock, and at the end, the societal benefit is much bigger than the investment here. It's about 4 times. So you see, that is about One Health, working on animal health to protect the human health and also to save money for the whole society. And that is actually the job of the government and private sector to invest in this mass vaccination, rabies, to eradicate rabies in Africa. We have also solution. At the end of the day, we need to invest. And if you invest for the next 30 years, the same study from Jacob, you can save about $10 billion for the whole continent for 30 years of agenda of rabies vaccination. If you put the mass vaccination in the agenda here, you can read more detail on that. Okay, I think that I come to the end of my talk, and just to say that INRI work on One Health for the last 4 decades, but mostly very active in the last 2 decades, and we review 24 projects with the value from $1 to $15 million, and actually on this analysis come up with some recommendation, and we realize that we need to make stronger cross-sectoral collaboration, greater engagement, and with policymakers to translate research finding, which is very good, but it's not very much translated on the ground. And the development of innovation needs to be context specific in some of the place that we are working. We had One Health conference in South Africa for the first time. Congratulations South Africa for hosting very successful the meeting last year. We have ISVI coming up, and some of the meeting we always come up with the recommendation. And here, one of the recommendations from Cape Town meeting last year is really the engagement again of private sector market players to join the dialogue to accelerate the One Health operationalization at the global level and country level as well. So every have to be together. So let me conclude from all this explanation. So I hope that I have an overview for you and convince you that One Health is an important approach to address complex health issues. Zoonotic diseases, AMR, food safety, climate change, nutrition, and so on. But we are missing some of the component in One Health, in particular plant health, soil health, biodiversity. When you talk about food system, the environmental health is there, but not very strong yet. We need to do more from that perspective. Like recommended in the paper review from INRI, we need great engagement with policymakers to translate research into policy and also develop specific interventions to the context. Very key issue is about how to operationalize One Health. So we need more evidence on economics impact of One Health. Like I show the example of preventing the next pandemic from the World Bank, brucellosis in Mongolia, rabies in Africa. We need to put data on the table to convince our Minister of Health, Minister of Finance to invest in One Health. It can be prevention, it can be vaccination, it can be anything linked to One Health. Probably digital solution and AI would be important for One Health as well in terms of disease, surveillance, and so on. And the big goal for different partners, in particular policymakers, to invest in One Health in the country, in the county, in the local level. Because at the end of the day, many projects of One Health up to now have been supported from the global north. country are interested in One Health, we need to be interested. We need to prioritize that. We need to put money on the table. Pandemic fund only have 800 million for the last 3 years. We need 11 billion a year to prevent the next pandemic. So I think that the country or the county government, you need to actually look at the evidence of One Health and invest in One Health and take One Health as one priority in the agenda. Because when you take it as a top priority or good priority, you will have to put resources to have One Health work. And this is actually the key message to make One Health operationalized in different level to protect our health, animal health, and ecosystem health. That's why we're not talking about tree health. We talked about One Health because we want to unify approach to improve health of the people, animal, and the ecosystem together. With that, I would like to thank you very much for the attention, and I look forward very much to questions and discussion, and I look forward also to meeting many of you from tomorrow on site. Thank you very much. Back to you.